Welcome to the Misunderstanding Dementia Show. This episode is brought to you by the Alzheimer's Disease and Dementia Care Seminar, the required course to be a certified dementia practitioner. Check out our website at drmikechua.com/ADDC. Enjoy the show.
Hello everyone, this is Dr. Mike Chua, physical therapist and certified dementia practitioner, and today we've got a special guest here, and her name is Miss Linda Barker. She's a physician assistant here at Martin Orthopaedics, and oh my God, that was long, but we're here to interview her, ask her where's she from, what does she do, and what are the common cases that she sees here in Martin Orthopaedics. So again, thank you very much, Miss Linda. I appreciate you for having for coming over for our show. So basically, we have our show called Misunderstanding Dementia, wherein we provide education for different caregivers, different patients who have actually dementia, and teach them, bring out the best in them. And we encounter a lot of orthopedic questions too. Basically, patients who have hip replacement, knee replacement, shoulder replacement, whatever, and especially with dementia patients. So we're happy to have you, Ms. Linda. So thank you.
Well, thank you. I appreciate this opportunity. I grew up in upstate New York, area very similar to Martin, other than we had higher taxes, but in Binghamton, and decided I didn't want to stay in the northeast where it was cold and long winters. So I went to undergrad. I went to college in Ohio at Ashland College. It's now Ashland University, and that's where I got into athletic training. So that's kind of my into medicine, so to speak, beginnings. But in that setting, you're dealing with healthy people who happen to get hurt. So it's a little different. Did that for, finished undergrad, went to graduate school down in Mobile, Alabama, at the United States Sports Academy, took a few classes as well at the University of South Alabama. Also worked as the head athletic trainer at South Alabama while I was doing my master's. And then from there, I took a job here in Martin.
Why here in Martin?
Well, it was kind of halfway. You wouldn't have the super hot summers maybe, and you wouldn't have the bad winters. So
okay.
And it was a great job opportunity. Started at UT Martin working as a women's athletic trainer and taught some classes, and then I became the athletic trainer and kind of covered all of the sports at UT Martin, and also taught and had the athletic training area. So that I did that for 18, 19 years.
Oh wow!
And then did a year of kind of clinical work as an athletic trainer and did some outreach with the hospital. We had a clinic and got started with a lot of the junior highs and high schools that now that program still kind of goes on, although with different clinics, but that still kind of is going on in outreach to help out the community. And so
that's here in Martin.
Yes, sir.
Oh wow!
And Obion County. We did Obion County as well at the time. So then I decided I kind of wanted to do more, take it further. Like I said, as an athletic trainer, you typically are working with people who are healthy people who happen to get hurt. Well, there's a whole other population that maybe aren't, and take, education-wise, medicine-wise, further from myself as well. So that's when I got into the physician assistant program at Bethel College. It's now Bethel University up in McKenzie. Actually, the very first physician assistant that came out of their program, because my last name starts with B. So
you heard that, okay?
Initially came out, started working with Dr. Peter Lund, orthopedist here in Martin. And then Dr. Lund left, and then Dr. Ragsdale's been here, and so I've been working with Dr. Ragsdale here at Martin Orthopedics for the past 7 years. And we're a general orthopedic office, so we see all kinds of stuff. I may see a patient who's 12 months old, and then the very next patient might be 80 years old.
That's
so there's
right.
a wide range of what we see. So we see a lot of different variances there. We see a lot of in our older patients, obviously, osteoarthritis that happens to, unfortunately, pretty much all of us at some point. Wear and tear that happens with our bodies. So we see that a lot. And some of our patients have dementia or Alzheimer's, that kind of thing. And so that sometimes is a factor in
a big
the
challenge.
care. So, but then again, we may see the 10-year-old that got hurt playing soccer and those kind of things. Of course, we see fractures, ankle sprains, tendonitis, arthritis. So we see a wide gamut, gout, flares, things like trigger finger, which you don't typically think of in your younger population, although it can happen.
Nowadays, it's probably more common now.
But we see a lot of trigger finger, carpal tunnel, those kind of things with the hand and wrist. So knee injuries, the whole gamut,
Wow. Well, for our audience right now, she mentioned about osteoarthritis. So I know it. I know she knows it. But would you mind sharing what is actually osteoarthritis for our general audience right now?
Sure. Osteoarthritis is kind of the wear and tear of the articular cartilage of joints. And then that wears down, then if it gets bad enough, it's exposed bone. And can be very painful and disabling for patients. But it's usually generally through a process, although if you've had an injury earlier in your life, that can help set that up and make that more likely to occur. But if you've ever, and this is going to kind of sound like a funny analogy, if you've ever had the drumstick at Thanksgiving or Christmas, and you nibbled everything away, and all that's left at the end of the bone is just the bone, and on the end of the bone is that kind of white, silvery stuff at the end. That's the articular cartilage. That's what we wear away with osteoarthritis. And so most of the time we see patients that have osteoarthritis. Sometimes we see patients that have rheumatoid arthritis, and that's a little different animal, so to speak. It's a very inflammatory and can cause a lot of deformities, and that's more of an immune compromised problem, right? So those are the two different ones.
Is there any difference in the joint? Is it supposed to be the weight-bearing joint, or just the distal or proximal?
That's a good question. Most of our arthritis, I guess probably the largest percentage of the osteoarthritis things that we see are involving the knee or the hip, because they are weight bearing, and that's more prone. But we do see it in the hands. A lot of the base of the thumb, carpal MC joint, the base of the thumb, that's a pretty common one, particularly people that are older, and maybe they had jobs where they use their hands a lot, and that we see that quite a bit. You see a lot, these last joints in the fingers. Sometimes people will get these little tuberculin nodes, and sometimes they get kind of a little crooked and that kind of thing, and that shows up. So that's most of the time. Now we've got some that get some arthritis in the shoulders. Tend to see that more maybe with people that had a lot of overhead heavy duty kind of work in there when they were younger, kind of thing. But we have seen more in the shoulder than probably in the last 10 years. I've seen more now.
Oh wow!
So that seems to be a little more common. But most common by far is the knee. And sometimes the hip too. And so if you get somebody comes in with knee pain, you kind of want to check that hip too.
That's true. If you like what Miss Linda said. If you have any knee pain, you might also want to check your hips and actually also your back, because there is what you call a band here called IT band, your iliotibial band, that runs from your hip all the way up here, all the way down to your tibial area. And if that is tight, and it affects everything. So our body is a fascia, like what she said. When you have problems in your knee, you might want to have your hip checked too. So
we see a little bursitis too. And you're talking about the IT band, up there at the hip. If you got lateral hip pain, you notice no injury, but you notice pain, laying in bed on your side, getting in and out of the car or something like that. You can have bursitis in your hip, and that's not such a big deal. We inject those a lot, and then sometimes the therapists work with that a lot to try to stretch things out to take tension off it. So that's really common too.
She mentioned bursitis. Remember when you say we want to break it down, a lot of people, what is that term? What is that term, Michael? What is that thing there? When you break it down, bursa means pocket. Okay, bursa means pocket. Itis means inflammation or irritation. So when she said bursitis, it means there's an inflammation on that pocket, on that specific area. So thank you for pointing that out. So that's the problem there. There's an inflammation on your bursa, or your pocket in your area. I wish I have an inflammation on my actual pocket, back pocket, right? Where I get more money. Well, anyway, Ms. Linda, you mentioned about injections, and in no way we are not prescribing right now. We're not your physician or your doctors right now. This is just a medical general information. Okay, so right now, what are the most common treatment that you do, for example, for knee pain or hip pain or bursitis? Can you recommend any
Sure.
with treatment or something like that?
Typically, like for example, knee arthritis. You got to look at how much you weigh. If it's a weight-bearing joint. So one of the things is, if you can lose a little weight and take pressure off from it with weight bearing, that's one thing to consider, although that doesn't happen fast. But that's something to always try to work on, is trying to lose a little bit of weight if you're heavier. Obviously, if you're skinny, you don't need to lose weight.
I need to lose weight.
And then, things like over-the-counter Tylenol arthritis, if that's okay in your medical history. In general, that's something we recommend trying. Some home exercise or physical therapy.
Physical therapy.
Sometimes if it's been bothering somebody long enough, maybe your muscles have atrophied or gotten a little weaker because that knee hurts, so you don't walk quite the same. So sometimes we send folks to physical therapy to work on building that muscle back up, showing people the type of exercises to do when you have arthritis. It's a little different than somebody that has arthritis in the knee versus somebody that's a high school basketball player.
That's true. That's
they
true.
want to be pounding and increasing that pain. Sometimes we inject. We have different types of injections. We use corticosteroid, use a little numbing medicine with it, and inject the joint. As long as there's no, infection or, any chance it's infected, we wouldn't want to inject it. But as long as we know it's arthritis, we would do that. And we determine arthritis usually in our office by doing x-rays. We can see different compartments, the inside of the knee, the outside of the knee, behind the kneecap, and see if that looks like that's worn, and we can tell by spacing there. So we'll usually do that. So may offer that steroid injection, although if you have diabetes, you always have to worry about the corticosteroid elevating your blood sugars. So sometimes we err on caution. If the blood sugars aren't well controlled, we may not jump into doing that. But if if you don't have diabetes or you're well controlled, then that's a good option to try and settle that inflammation down. A steroid shot doesn't cure arthritis. It tries to settle down the inflammation that's creating the pain. We have another type of injection, although it's expensive and we have to go through insurance. Hyaluronic injections, and there's different companies that make it. It's actually made out of rooster cone cells.
Is this the hyaluronic shots? Okay, all right. So
it's made out of the rooster cone cells, which are very similar to the cells in the articular surface, articular cartilage of the joint. And it's only approved for the knee. It has a little thicker viscosity, and as long as you're not allergic to birds, feathers, chicken, eggs, then you could qualify if your insurance will cover it. And that idea there is it kind of gives you a little cushion, kind of helps out that joint capsule. So that's another option. Sometimes we try braces. We have a medial unloader brace that we use because most of the arthritis is typically on the inside. Sometimes it's on the outside, but we have a brace, either medial unloader or a lateral unloader. That the engineering behind it is to kind of take tension off that side where you have the more arthritis in. So you think about it.
I'm learning so much here today, guys. So
you think about the arthritis is decreased spacing because the articular cartilage is being worn. So a lot of times I was like, gosh, when I stand, it just hurts me on the inside of my knee. Well, this medial unloader brace, the mechanics or the engineering behind it is put pressure on the lateral side and take pressure off the medial side of the knee. So that's something to try. Does it work on every patient? No. But it's an option to try. So those are kind of the things we start with. Occasionally, as it progresses, sometimes folks end up having a knee replacement. And that's when Dr. Ragsdale comes into play. And sometimes we have folks that end up having a knee replacement. It's a big decision. And usually it's left up to the patient when they make the decision, not necessarily us, because it's a quality of life thing.
That's true. That's true. I like what, I don't know if you were actually actively listening there. I don't know if you noticed it. They are approaching it as a holistic approach. I like what she said, you have to control the inflammation, the irritation first before you could start doing anything else. Because just like anything, if you are, as a physical therapist, how can I move a patient if they are in a, in an irritated mode? Same thing with the joint, like what she was talking about. How can you move and exercise it if it's still irritated? So what they're trying to do, I don't know if you notice it, she recommended, simple Tylenol. You can also put some ice on it, to reduce the inflammation. She also recommended the steroids to decrease the inflammation. But of course, you got to talk to your doctor, In that way, if you're diabetic or not, because your steroids again can increase your blood sugars. So you have to really be careful about that too. Well, I like what she said too, bracing. I don't know if you heard it, she mentioned about supporting it on the right way of bracing. If your knee is going inside, or we call it genovalgum, it's basically going inside, obviously you put the support on the opposite side, and that's where they come in, trying to analyze. So you have to make sure you go to a really good qualified physician assistant, and that way they can really identify. Gone are the days when you go to a physician wherein, okay, this is it. It's not, it's not that. You need to go to somebody that actually knows how to specifically take care of you. And this is where you're supposed to go. And of course, she also talked about quality of life. And sometimes of those conservative treatments, therapy, exercises, steroids is not working. That's again where surgery comes into play, and obviously you have to improve your quality of life.
And a couple other things too, like sometimes we'll try some other non-steroidal anti-inflammatory medications, and again that's based on what your medical history is. Some things you don't want to combine that, but that's another medicine option. And then sometimes we add things that folks don't usually want to go to, but might need to. Things like a cane or a walker. Taking pressure off that joint when you're weight bearing to make it where you can get around and more comfortable and less pain. So those are things we sometimes send also to physical therapists to help with that, to using those correctly.
Proper using of, I love what you said, sometimes you have to have assistance. If you're a caregiver, by the word itself, caregiving, you cannot give what you do not have. Same thing with walking, with your pain. If you are hurting when you're standing up and walking, imagine I weigh 200 pounds. 210, okay? When I'm standing up and walking, I'm stepping, when I'm lifting one foot, I'm putting my 200-pound body in one of my knee. And that's putting the whole pressure there in one of my knee. But if you have a cane, or actually a walker, it relieves that pressure on that affected extremity. So that's true. Thank you for reminding us that we need to use assistive devices. So.
And things, if somebody has access to a swimming pool, the buoyancy of the water, that's great. You can do more things in a pool than you can on dry land. A recumbent bicycle, all those things that kind of with therapy too would definitely be an advantage.
I love that. Hydrotherapy or water therapy. Like what you mentioned, the buoyancy, it relieves the pressure in your body, and actually the pressure of the water, the hydrostatic pressure, that's actually really good too in your knees. So thank you for sharing this, Linda. I'm learning. It's refreshing my mind here. All right, it's like just to let you know, she's actually in the Hall of Fame of University of Tennessee, athletic trainer Hall of Fame. I just read it here. So
UT Martin.
UT Martin. So, well, any last parting tips for us, Miss Linda, as a therapist or as a patient patient out there who are having knee problems, hip problems?
Well, take care of your body. You only have one. So listen to your body. If something's hurting, follow up with your regular provider, and they may send you to our office or any other orthopedic office, or your physical therapist. Your body's telling you something's wrong for a reason. And try and follow healthy lifestyle as best you can. And we all kind of go off the path a little bit, but in general, that helps your body last longer. And if there's anything we can do to help you, we don't mind. Give us a call.
Thank you very much again, Miss Lynn.
I appreciate you having me.
Well, I appreciate you for having for this awesome opportunity. All right, I like what she said. You got to take care of your body, okay? If you're watching right now, listening in our show, in our podcast, and I already mentioned it, you cannot give what you do not have. If you're a caregiver right now, taking care of a dementia patient, taking care of a loved ones, if you're a caregiver, you cannot give what you do not have. That's why it's called caregiving. You're giving care, okay? And like what you said, you only have one body. Remember this, self-care is not selfish. You gotta take care of yourself. Again, thank you very much, Miss Linda. Can you tell us your telephone number here and our address?
Our office is located right across from Volunteer Community Hospital here in Martin. Our, the official address is 164 Mount Pelia Road, and we're Martin Orthopaedics. Our phone number is 587-5900.
Thank you very much. We will also put that in our show notes. we will put the website, their telephone number, and also the address. Again, thank you very much, Alternative Careers Group. Thank you very much, Mr. Understanding Dementia. I appreciate you, and always remember the word FAST, F-A-S-T. First is you have to find friends that will push you to your next level. Right now I'm friends with Miss Linda here, and I go around and interview different people. You gotta find people that will push you to your next level, because you are the average of the 5 people you hang out with. And next letter A, you gotta learn how to take action. Why? If you're a caregiver, take action. Take care of yourself. All right, take care of yourself. And letter S, you gotta learn how to shoot for the moon, because when you miss it, you're gonna be eventually landing with the stars. And last but not the least, letter T, not time out, but teach it. And that's the reason why I'm here. I'm asking Miss Linda to teach us, right? And, you need to learn how to teach it. Why? Because when you hear it, you forget. When you see it, you remember. But when you're actually teaching it, that's like Miss Linda's doing. You're learning it and understanding it more. Again, thank you very much. I appreciate you.
Right.
Thank you, Miss Linda.
Thank you.
Hope you have a good day. Thank you.
Thank you.
Thank you, Miss Linda. Appreciate